This pathologist Dr. Ranjit. So let's go and discuss one more case, an approach to an intestinal biopsy. So this is a lesion from the rectum. I'll be giving you a brief description about it, and let's go one by one. And for ease of comparison, I'll be noting down few points here. I'll use my cursor to look at it, and also I'll compare to one more lesion so that we can actually differentiate what exactly happens here, right? So first, superficially, if you look at this image, what you can see here is, you do see a good amount of epithelium here, but if you can see here, the epithelium is kind of denuded, right? You don't have an epithelial lining here. Yes, I have glands below the epithelium. Please do understand. I'll go to a different area. Please do understand here. This is the overlying epithelium, right? So this is the surface epithelium here. But if you look at this part, I don't have a surface epithelium. There's no surface epithelium, right? There's no surface epithelium here. Yes, I do have glands underneath. I'm not talking about them. I don't have a surface epithelium, right? So that's our first finding here, which I want you guys to concentrate. There's a superficial loss of epithelium. Loss of any epithelium in its skin or mucosa, we're going to call it an ulcer, right? So first thing which is clear for all of us here is we do have a superficial ulcer in this patient, right? So apart from the superficial ulcer, are we seeing any finding in the low power microscopy? Yes, there are few dilated glands here and there. We do see a little bit of insufficiented mucin here. Apart from that, I think let's go to the higher power to see what it is. So when you see a superficial ulcer in case of an intestinal biopsy, I want you to think of few infective causes. It doesn't look malignant in this power. You don't have much of an your pleomorphism, your high NC ratio, or an distorted appearance here in this. So I'm primarily thinking of an inflammatory pathology. Let's see. Let's go to the higher power to prove whether it's right or wrong, right? So let's zoom in a little bit here. You can see that there is a very well preserved architecture. You can see the mucin present. Actually, loss of mucin is one of the earliest feature for dysplastic change in case of an intestinal biopsy. Please do remember them. One thing which I can notice here, below the epithelial ulceration, you do see good amount of capillaries. That's fine. That's kind of a granulation tissue, right? So don't think this is an abnormal thing. Anywhere you have an ulcer, below that healing process will start. So definitely you'll have the capillaries in abundance. At the same time, if you go to the ulcer a little bit away, so you can see a little bit of necrotic, kind of a dirty material here, right? So this is what I want you to know it as a pseudomembrane. Let me zoom out a little bit. So you have an epithelial ulcer. On top of that, you have a good amount of pseudomembrane. Please wait. Do not jump into pseudomembranous colitis here. We'll definitely discuss about that sometime soon, right? So you do have a pseudomembrane here. You do have an ulcer here. And below the ulcer, yes, you do have good amount of capillaries. Let me zoom in. There's one particular change in this lamina propria. I am not sure how many of you noticed that. If you look at this lamina propria, it's not as like a usual lamina propria, right? I'll compare it here. This is how a lamina propria looks. Look at that. It's more like kind of a very loose connective tissue, right? But if you look at this lamina propria, in our case, it's a bit pink in color. Generally, you don't have a pink lamina propria in case of an rectal biopsy, right? This is an rectal biopsy. Like I said, I won't have that much about one thick lamina propria. And if you look at the lamina propria, not just the pink color, actually there's more cellularity as well, right? There's a little bit of more cellularity. All these are spindle shaped structure, good amount of cellularity. So here, can I call it, I want your approval here, can I say that this patient has good amount of fibromuscular hyperplasia in the lamina propria? Yes. This is definitely fibromuscular hyperplasia. You can see the fibers here. Yes. As opposed to a normal lamina propria here. It's more of loose connective tissue here, right? So here I do have a fibromuscular hyperplasia of lamina propria. That is a very important finding as well, right? At the same time, I'm going to zoom out a little bit to go below. You can see this part. There is a good amount of smooth muscles here. This is not your muscularis propria, muscularis mucosa, by the way. This is your muscularis propria. You have an epithelium, lamina propria, and muscularis propria. If you look at this muscularis propria, again, I'm noticing a very, very important thing. It's not uniform. It's been splayed. Look at this. It's coming here, splayed, right? It's kind of been distorted. I have a thick muscularis mucosa, definitely. Right, there's a definitely thick muscularis mucosa, not the muscularis propria, but you see below the submucosa. There's a muscularis mucosa, it's thick and it's definitely splayed. That also a very characteristic finding here. At the same time, when you go here, let's just scan through it. See, everywhere I have the same thing, right? At the same time, let me zoom out a little bit. What I can also see is good amount of ectactically dilated blood vessel. Right? This is not how I am just going to compare it with the normal lamina propria and the normal submucosa. Look at this. This is how the capillaries look in the subepithelial tissue, right? They will not be dilated like this, right? So I do have an ectatically dilated blood vessel, that's also there. Little bit of inflammation here and there, definitely there. I do have a little bit of your calcific change also in this field, right? Now let me go to the membrane again, so the epithelium again. I just want to look at few places where you have focal dilatation of the crypt. Not throughout, I do have focal dilatation of the crypt. That's also a classical finding in this patient, right? Focal dilatation of the crypt, right? You do have the focal dilatation of the crypt, right? So I'm just going to point out one by one. I do have an ulcer here. I hope you agree with that. And also there's a pseudomembrane here. Yes, there is focal dilatation of the crypt. There is something called a diamond shaped structure here, which is not there, but I would say that this is definitely an irregular gland appearing here, that I can include as a diamond shaped gland, right? Then I do have good amount of fibromuscular hyperplasia in the lamina propria. I hope you accept that. Compare this with a normal intestinal lamina propria. Definitely pale, definitely pink, and fibromuscular. Look at this, definitely good amount of fibromuscular hyperplasia. Not just that, when I go to the muscularis mucosae, it's definitely thicker and it's been splayed with ectatic blood vessels and little bit of inflammation here and there. This is how a classical appearance of solitary rectal syndrome looks like. You can take any book of the GI pathology, open it, and please look at all the points. I'll also put the classical findings of your solitary rectal syndrome in the pinned comment as well. I just want you guys to learn more and listen to more, right? So share this with your guys who find it difficult to report a solitary rectal syndrome or an intestinal biopsy. Let's read more and more and more things about pathology and medicine. Bye bye.